selective at muscarinic receptors, which means they activate all muscarinic receptors, M1, M2, and M3. The first thing that I look at when I'm thinking about a list of drugs are easier ways to remember the names. When it comes to muscarinic agonists, think about the four letters CHOL. CHOL, found in acetylcholine, found in bethanechol, and found in methacholine. At least that helps me with the first three in this table. A little bit harder to remember drugs like pilocarpine and cevimeline, but those are also important drugs that are muscarinic agonists. Let's start with acetylcholine. Can you come up with 2 reasons why acetylcholine is not a very useful drug? Well, the first one should be pretty obvious. Short half-life. Because it's rapidly metabolized by acetylcholinesterase, really it's too short to be of any real clinical benefit. The second reason maybe why you would not like acetylcholine as a drug is it's not selective for muscarinic receptors. In fact, it's going to activate all muscarinic and all nicotinic receptors. So a property of the other drugs in this table are this. They're all more muscarinic selective, and they all have a longer half-life compared to acetylcholine because they're more resistant to hydrolysis by acetylcholinesterase. Let's look at bethanechol. Bethanechol is an important drug that can be used to treat postoperative or neurogenic ileus and also patients with urinary retention. So if you have a patient who shows up and they have decreased GI activity or they have decreased GU activity, they can possibly benefit from bethanechol. It's a drug that stimulates bowels and bladder, and that's an easy way to remember. How about bethanechol for bowels and bladder? Of course, in order to use this drug, it has to be a non-obstructive ileus and a non-obstructive urinary retention. Then we've got the drug methacholine. This drug can be used as a diagnostic for bronchial hyperreactivity. This would be in a patient who has subclinical asthma. For example, you suspect that the patient has asthma, but perhaps you've received normal spirometry results when you tested the patient. We now do what's called a methacholine challenge test. Methacholine as a muscarinic agonist is going to be a potent bronchoconstrictor. That bronchoconstricting effect can help you to diagnose their bronchial hyperreactivity. Then we have the drugs pilocarpine and cevimeline. Both can be used for xerostomia, dry mouth, because these drugs can actually increase salivation. This shows up often on an exam in a patient with Sjogren's syndrome. It's an autoimmune disease. You get lymphocytic infiltration of the lacrimal and salivary glands, and oftentimes these are female patients in their late 30s, early 40s. If you had to describe a patient with Sjogren's syndrome with one word, I would have to say that word would be dry. They've got dry eyes, they've got dry mouth. Because it's common in women, vaginal dryness is another part of that scenario. We want to give them a muscarinic agonist to increase fluid production. Of course, be aware, many times you get a test question where they describe the scenario. You're asked basically to make a diagnosis, Sjogren's syndrome. You're then asked to think about what a treatment option would be, perhaps pilocarpine. But isn't it common that questions will often go on to tell you what drug you're going to use? You thought that was going to be the question, and instead they go on to say, so you have decided to give this patient the drug pilocarpine. That's very frustrating. The question goes on to say, which of the following side effects should the patient be monitored for while taking this medication? Well, that's easy if you just think about all of the different properties that we've reviewed for a muscarinic agonist. For example, this patient might experience diarrhea or excessive urination due to the GI and urinary stimulating effects of muscarinic agonists. The other use for pilocarpine is glaucoma. Formerly, this was an important use for this drug. Today, we have a lot of other glaucoma medications that we actually prefer over pilocarpine, but that's still an indication for this drug. This table looks at our acetylcholinesterase inhibitors. For your step 1 exam, this is a very, very important list of drugs. Many different uses for these drugs, many different properties that we have to be aware of. Let's start with edrophonium. Edrophonium is a short-acting drug used as a diagnostic for myasthenia gravis. Myasthenia is a very popular condition to show up on your step 1 exam. If you want to diagnose the patient, you can give them edrophonium. This is a drug that's going to increase the levels of acetylcholine. The patient gets a return of their muscle strength, and that can assist you in diagnosing this condition. Then if you'll notice, we have several stigmines in this table. In fact, the ending stigmine is very important to remember. If I ever see that ending on a drug name, I know that is an acetylcholinesterase inhibitor. But physostigmine is separated from neo and pyridostigmine in the table because physostigmine is a tertiary amine. A little bit of chemistry here. Physostigmine as a tertiary amine, those types of drugs are very, very lipid soluble. So this drug can enter the CNS effectively. Whereas neostigmine and pyridostigmine are quaternary amines. That means they have an extra hydrogen in their structure, giving them a positive charge. These drugs are very water soluble. They don't enter the CNS. So there's the difference between those three drugs. Physostigmine is most commonly used as an antidote in atropine overdose. If I reminded you that atropine, the prototype of the muscarinic blockers, is also a tertiary amine. Atropine can go into the CNS, and obviously atropine can work in the periphery. Don't you need an antidote that can stop both the central and the peripheral effects of this drug? Absolutely, and that's what physostigmine can do. Neostigmine and pyridostigmine would not be as effective as an antidote for atropine overdose because they're only going to stop the peripheral effects. So when I think about using these drugs, it is just for their peripheral benefit. The first two indications, ileus and urinary retention, to me are more common to treat with bethanechol. And the reason I would think of bethanechol first is it's a muscarinic selective drug, whereas acetylcholinesterase inhibitors, by raising the levels of acetylcholine, would have not only muscarinic effects, but also nicotinic effects. So a greater potential for side effects for using these two drugs. So what would I focus on for using neo and pyridostigmine? The treatment of myasthenia gravis. I want to treat myasthenia by increasing the levels of acetylcholine, stimulating the skeletal muscle to contract. I use these drugs as treatment because they have a longer half-life compared to edrophonium, the very short-acting drug used as a diagnostic. I can also use neo and pyridostigmine to reverse non-depolarizing neuromuscular blockers. If I think about those types of drugs, you think about drugs like atracurium, mivacurium, pancuronium, vecuronium, those non-depolarizing neuromuscular blockers. What does myasthenia and non-depolarizing neuromuscular blockers, what do those things have in common? They both involve the same receptor. In fact, if I said, what are the antibodies targeting in myasthenia gravis? You would say they would be targeting nicotinic N sub M receptors found at the neuromuscular junction. That's exactly right. What do non-depolarizing neuromuscular blockers target? What type of receptor do those drugs block? They also block the N sub M receptor. So that's what we're dealing with. We're dealing with two conditions that involve N sub M receptors. In both cases, if we raise the levels of acetylcholine, we can have some therapeutic benefit. In fact, let's explore that myasthenia patient a little bit more, because this is such a very common condition on the test. The patient is going to present with muscle weakness. Obviously, that can be weakness in muscles in general, but drooping of the eyelid, ptosis. You can also see difficulty in chewing and talking and swallowing. Those are all part of the patient presentation. The more the patient exerts themselves, the weaker they get. So the symptoms improve with rest. If you did a comparison between myasthenia and Lambert-Eaton syndrome, what is the difference in those two patients? I mean, What happens with a Lambert-Eaton patient when they exert themselves? That's right, their symptoms improve. What is it that the antibodies in Lambert-Eaton are actually targeting? Because it's not N sub M receptors, it's calcium channels. That's correct. So with continued exertion, the patient with Lambert-Eaton accumulates enough calcium to get muscle contraction. So they get better upon exertion. Always a good thing to stop and do a side-by-side comparison of similar conditions whenever you can. We move on now and discuss the drugs donepezil and rivastigmine. These are two lipid-soluble drugs that are both used in the treatment of Alzheimer's disease. There's a clinical correlate in the margin that we will discuss in just a moment related to this condition. We'll talk about exactly why an acetylcholinesterase inhibitor would be beneficial for this condition. Finally, we've got organophosphates. Now, this is a very special group of drugs, and here's what you should note. These drugs are irreversible inhibitors. You see, all other acetylcholinesterase inhibitors in this table, they're reversible. They're less dangerous compared to these irreversible organophosphates. It's the irreversibility of this drug that means we perhaps need to consider multiple antidotes for a patient who's been exposed to this type of drug. We see organophosphates used as insecticides. So malathion and parathion would be examples. And insecticide poisoning is a very popular question on the test. If you see that question that starts off discussing a 37-year-old farmer, perhaps you're considering insecticide poisoning as a possible scenario there. You also have to think about nerve gases. Sarin or VX nerve gases could also be a test question. These are irreversible inhibitors of acetylcholinesterase. They're obviously going to have pretty significant and possibly fatal effects on a person who gets exposed. Again, this makes for a very good test question. In the margin is a note about Alzheimer's disease. Again, characterized by late onset dementia, progressive memory loss, and cognitive decline. You know, many people when they discuss Alzheimer's disease, they remember the neurofibrillary tangles, the amyloid plaques. But what I want you to consider is what is the rationale behind using acetylcholinesterase inhibitors to treat this disease. Remember, it's because of loss of cholinergic nerves in Meinert's nucleus. Another way to say that is patients with Alzheimer's have less acetylcholine. When we use an acetylcholinesterase inhibitor, we can increase the levels of that transmitter and have some benefit in the treatment of Alzheimer's. There's an easy way to remember the side effects caused by acetylcholinesterase inhibitor poisoning, especially if you're thinking about organophosphates. That overdose, that exposure type situation, very popular on the exam. The mnemonic that we use to remember these side effects is dumbbells. That's right. It's a mnemonic that you have to practice spelling, by the way, because dumbbells, the second part of that is not spelled how you would normally think. In fact, if you were to take the word bells and double every letter that's not supposed to be normally doubled, you could actually come up with 2 B's, 2 E's, 1 L, and 2 S's. When I look at the different parts of dumbbells and I identify what's going to happen, like diarrhea, your challenge should be to indicate exactly what receptor mediates each symptom. If I think about what receptor causes diarrhea, for example, that would be overstimulation of, that's right, muscarinic M3 receptors. What about urination? That's also M3. Meiosis, pupil constriction, that's M3. Bronchoconstriction. On the lungs, you also have M3 receptors. Okay, be careful. What about bradycardia? That's right, the heart has M2, so that would be M2 activation causing bradycardia. Emesis, the fact that you can get some nausea and vomiting with acetylcholinesterase inhibitor poisoning, perhaps that's related to M1 receptors in the CNS. Now, excitation, we're going to skip that one just for a moment. Come back, we'll focus on that in just a moment. We'll come back to that. Lacrimation. Lacrimation is M3. Salivation, that's overstimulation of M3 receptors. And sweating. Sweating is also caused by muscarinic receptors, and those receptors are M3s. Isn't it true that most of dumbbells is M3 mediated? Exceptions up to this point have been bradycardia, that's M2, emesis, M1. But let's focus on excitation, especially excitation of skeletal muscle. Now, what receptor is that? If it's skeletal muscle, that's N sub M. That's the receptor at the neuromuscular junction being overactivated. If I said excitation of the CNS, can you identify two receptors that might be involved in that action? The muscarinic receptor that would be involved in excitation of the CNS would be M1. But what about the nicotinic receptor? That's right, N sub N. So excitation is a little bit more complex because it involves, many cases it involves nicotinic receptors, but also could involve muscarinic receptors. When I think about insecticides, remember that these are long-acting, irreversible inhibitors. They can be subcategorized as carbamates or organophosphates. Used in agriculture, drugs like malathion and parathion. We have a diagram that shows you why these are more selectively toxic to insects compared to humans. For example, parathion and malathion are actually prodrugs. They have to be activated by P450 enzymes. That happens very quickly in insects, but very slowly in us. So the insects rapidly convert these drugs into their active form. And then there are other P450 enzymes that inactivate this active form. That happens very quickly in us, but very slowly in insects. And so what that means is the active ingredient of these insecticides accumulates in the insect and is less likely to be formed in us. With all that being said, however, if you have a person who gets exposed to a large quantity of an insecticide, it almost doesn't matter how quickly their P450 enzymes work, that person is going to be at risk for developing dumbbells. Your book has a very nice summary of the toxicity of acetylcholinesterase inhibitors. We have previously summarized by using the mnemonic dumbbells all of the different muscarinic effects and the different nicotinic effects. It's very important to understand the management of acute acetylcholinesterase inhibitor toxicity. Since we've identified using the mnemonic dumbbells that most of the side effects of acetylcholinesterase inhibitors were caused by overactivation of muscarinic receptors, you can imagine that a muscarinic antagonist like atropine would be very important. Atropine does a great job of relieving the symptoms associated with dumbbells. But if I were to ask you to think about what part of dumbbells atropine would not be able to reverse, what would you say to that? Muscarinic blockers can't reverse any of the nicotinic effects caused by an acetylcholinesterase inhibitor. Importantly, that would include skeletal muscle excitation. In fact, if I said, what part of dumbbells is most often going to be fatal? It's interesting because a lot of people would look at the B's. They would look at bronchoconstriction and bradycardia and be very concerned about those. And obviously you should be. But what's more likely to be fatal is the E. It's the excitation of skeletal muscle. And this is what this note reminds us of. It's permanent depolarization of the diaphragm, kind of an important muscle. You inhibit breathing and cause death. Because what happens is you are continually activating nicotinic receptors, N sub M receptors on the diaphragm. Eventually those receptors become desensitized and they stop responding. You paralyze the diaphragm, and that's what causes death. Atropine is not going to be able to stop that effect because it's nicotinic mediated. In that case, we can use a second antidote, a drug called pralidoxime. Pralidoxime is often abbreviated as 2-PAM. It's what's referred to as a regenerator. If you think about that term, it can regenerate acetylcholinesterase. The reason this drug can do this, do you remember how acetylcholinesterase inhibitors that we call organophosphates actually bind to the enzyme? They are irreversible inhibitors. They form very strong covalent bonds with the enzyme. Pralidoxime has the special property of being able to break that bond. It can break the bond between that nerve gas or insecticide and acetylcholinesterase. When you break the bond, you remove the poison, if you will, from the enzyme, and now acetylcholinesterase works. It has been regenerated. Once acetylcholinesterase can work once again, it starts to break down acetylcholine. When the levels decrease, including at the neuromuscular junction, you get the relief of all of the effects associated with dumbbells. Of course, there is a very critical component related to the timing of using a drug like pralidoxime, and that is because you can get time-dependent aging of your nerve gas or insecticide. Aging, sometimes referred to as chemical aging, is a process whereby the organophosphate changes its structure to such an extent that pralidoxime will no longer work. That timing sometimes can even be minutes with certain nerve gases. For drugs, it's often many, many hours before aging takes place. Here's our figure that looks at the effects of acetylcholinesterase inhibitors and how we can use pralidoxime as an effective antidote. On the left, you see the drug indicated as P, that's your organophosphate. Notice that the R sticking off of that is your leaving group. That is your functional group that is going to be removed in a process that we call aging. When you get right down to it, aging is really a hydrolysis reaction that removes that functional group. You must give pralidoxime before that happens. Give pralidoxime before aging takes place, and pralidoxime can effectively remove the organophosphate from acetylcholinesterase, thereby regenerating the enzyme. That's the reason why, if you've got a scenario, let's say you get someone exposed to a nerve gas that's an acetylcholinesterase inhibitor, you want to rapidly use your antidotes, atropine, and perhaps also pralidoxime, in order to quickly antidote this situation before aging takes place. There is a risk of chronic toxicity with acetylcholinesterase inhibitors. Patient can get some peripheral neuropathy, causing muscle weakness and sensory loss. There's possibly also demyelination that's not due to acetylcholinesterase inhibition. But when it comes to your step 1 exam, it's the acute effects of these drugs that are way more important than the chronic toxicity.